All right, so depression and physical symptoms. So Patrick Lussman, years ago, now 20 years ago, basically showed that as compared to poor metabolic control, as measured by hemoglobin A1C, depression was more highly correlated with reporting of 9 of 11 symptoms of poor glucose control, such as polydipsia, drinking too much, going to the bathroom too much, hunger, fatigue, things like that. And we did the same thing in our clinic a few years ago. We looked at 476 patients, and again, we looked at depression. You see the first column here, and then the second column is hemoglobin A1C, and you have 9, is it 8 or 9? 8 symptoms of diabetes. And what you see is the correlation between depression and these symptoms is much higher than the correlation between those symptoms and hemoglobin A1C. And we found that in, I think I have another slide, here we are. This is 4,000 patients at Group Health Cooperative. We did a study, we're still doing ongoing part of the study, a randomized control trial. This was an epidemiological study, and we looked again at these 8 or 9 symptoms of depression, diabetes rather, and we looked at how depression was associated with these symptoms. And what you see here, these are all confidence intervals. And so if the confidence interval is to the right of that line that's above the 1, that means it's significant. It's statistically significantly greater than people that aren't depressed. So it's interesting. You can see daytime sleepiness. People that were depressed had a 5 times higher likelihood of having daytime sleepiness, which can be a symptom of diabetes as well. Blurred vision, shakiness, abnormal thirst. I mean, how does that work? But that's, again, what did I call it before? Symptom amplification. It's really that whole thing of turning up the volume on the symptoms, the perception of symptoms that people have. You know, and it's really important to be able to talk to patients about that. It's incredible how much that does for a patient if you just explain it to them. The symptoms that they're having, they're often confusing. Any of these symptoms that they're having, they're often feeling very guilty, and there's a lot of self-blame, and they're confused by these symptoms, often physical or emotional symptoms, and it's good to explain to them that there's this symptom amplification going on. This is very common. You explain to them, and they feel like, oh, well, that actually helps. I don't feel like I'm going crazy. Depression and physical symptoms. So remember I said depression causes symptom amplification. It also prevents habituation to chronic aversive symptoms such as neuropathy. So for example, someone who has dysthymia or this smoldering chronic depression, let's say they get neuropathy pain, it may be that if the depression is ongoing, they might have these ongoing neuropathy symptoms to a greater degree than they would otherwise, to the point where they might even lose function and maybe even get disabled because the pain is so intense. And really, often treating the depression turns down the volume on those symptoms. So the other thing is, this is just another example from our study of 4,000 patients at Group Health Cooperative, where we found, looking at 3 different medications, oral hypoglycemic medications, lipid-lowering medications, and ACE inhibitors for hypertension. Again, the bars show that in the depressed group, the rate of non-adherent days, and this is from looking at pharmacy data. If you ask people, if you ask them self-reports, what people are often, there's social desirability or recall bias. But when you look at pharmacy data, and group health, where we did these studies, is a closed system. So we know how often they refill their medications, and these are pretty accurate. And so it's just proving what we already know clinically. And then we looked at hemoglobin A1C over 8% by depression. So we've got no depression, minor depression in the middle bar, and then major depression. And what you can see here, again, is this kind of dose-response curve between hemoglobin A1C, in other words, the proportion that had hemoglobin A1Cs over 8%, and the 3 types of depression that I already talked about. No depression, minor depression, which is 2 to 4 symptoms, or major depression, which is 5 or more symptoms. What about smoking? Again, you've got none, minor, and major, the 3 bars, and it goes from 7% up to double that, 16, even more than double that, 16%. Again, the sample size was about 4,200 people. And why do people smoke when they're depressed? It's a way of self-medicating. You know, smoking is one of those things that if you're tired, you smoke and it picks you up. If you're, the sluggishness of depression, it picks you up a little bit. If you're anxious, you smoke and it calms you down. It's one of those interesting drugs. And so it's very hard, and studies have even shown that, you know, often when people do stop smoking, sometimes they have been self-medicating their depression and they start to have depressive symptoms again. So you have to be looking for that when people do stop smoking. And then percent of BMI over 30 kilograms per meter squared, in other words, in the obese range, again, what you see, and at each one of these, it's statistically greater than the none group, so none, minor, and major. And you can see that the depression is associated with weight. And what about cardiac risk? And basically, this is showing that patients that had 3 or more risk factors for cardiovascular disease, 60% of them, or just slightly more, in the major depression group compared to the no depression group. And this is among patients without cardiovascular disease. So these are risk factors for getting cardiovascular disease. And then mortality, basically what it shows is that major depression and minor depression in both of these models was associated with greater mortality over in this study it was over a 3-year period, and we've recently done it over 5 years. And other studies have shown this as well. And in another study, this was a smaller study, also at Group Health, it just shows that the healthcare use in patients that's depressed, and this is not mental health care use, was 88% higher amongst people in the highest tertile of depression compared to the lowest tertile of depression. If you ask people, how often do you miss appointments? There's social desirability, tremendous social desirability. They're not going to tell you. So again, what we did is we looked at medical records for 18 months here, and we looked at canceled and missed appointments. These were primary care appointments. And then we looked at depression to see whether there was a correlation. And sure enough, what you can see is people with no depression compared to minor or major. And actually, the only significant difference was between major depression and no depression. It was about twice as much, roughly 22, 23, 24%, 23% maybe, versus 12%. So people were missing a lot more appointments. So somebody had mentioned, you know, lower appointments. And in fact, what we're seeing is kind of both, right? On one hand, people are spending a whole lot more money, but what's happening is they're missing appointments. It's chaotic use of health services. Does that make sense? Is that your experience? Yeah, you bet. We all know it, right? And then dissatisfaction with health care. And so what we know is that people are less satisfied with care. Again, we had a questionnaire. And at every level of depression, minor depression and major depression, people were far more dissatisfied with the care they were getting. So these are just examples from all the studies that we've done that really prove what we know clinically. And so now I want to talk a little bit about diagnosing it and why it's such a challenge. You know, even in the age of Oprah, where we talk about everything openly, you can just flip the channels and, you know, we can talk about depression and abuse and this and that. There's still a tremendous stigma about depression. You know, it's seen as a shameful or character weakness. And the other thing is that as clinicians, we're often busy in primary care settings. And as I was saying at the beginning, I was joking that we have lots of time. We don't have any time. You know, and it's sort of like fear of opening Pandora's box. Time constraints. It's the time constraints and competing demands. It just doesn't seem fair, but that's the way it is. And then, of course, there's lack of resources and the good reasons fallacy. The good reasons fallacy, where we collude almost with our patients. And family members might collude, and we say, boy, if I had those 4 or 5 medical conditions, I'd be depressed too. Let's get that depression, let's get that diabetes under control, let's get that hypertension under control, and when they start to feel better, you know, this is just a phenomenon of their depression. 5 years later, the person's still depressed. So I think we have to be careful that we're not getting, and again, because of the stigma, you know, families might want to not acknowledge that, you know, their mother-in-law or their mother's depressed or whatever, and I think it's just very important to recognize when we're kind of buying into this or colluding with it.